Welcome to the Friends of NPACE Podcast. I'm Terri Schmitt, the Executive Director of NPACE. I'm also practicing FNP, and I'm very excited to talk to the two people that I have with us today, our guest, Dr. Brad Haupricht, and nurse practitioner Bernadette Donovan. So I'm going to introduce you guys with bios, and then you can say a little more, and we'll jump right in, okay? All right. So Brad, you're a board-certified family medicine physician for 12 years. 9 you spent in private practice, and then you started in telehealth. But you also are board certified in sports medicine, and you've cared for athletes at all levels and Division I and Division III colleges. And you're in Virginia. You have a wife, a 14-year-old daughter, and when you're not with them, you are outside doing something in the Blue Ridge Mountains, except for not today because it's storming there, right?
Exactly. That's great. Thank you.
No, thank you for being here. And Bernadette, you're a family nurse practitioner. You have a bachelor's degree from Kenyon College, but your nursing degree is from Yale School of Nursing. And I said family, you're adult and like, women's care. Yeah, yes, no, you can correct me anytime. That's what we're doing.
Yes. Yeah. Adult NP and women's health NP.
Okay. Because one certification wasn't enough, right, Bernadette? I love it. Oh, that's even cooler. Yeah. She's passionate about increasing patients' access to care, especially for women. She's currently leading a team at Galileo who are building a virtual prenatal program, especially designed for patients living in maternity care deserts, of which we have a lot in the U.S. And when you're not working, you love to read. You are commonly engaged in 2 to 3 books at once. We should talk books because I am too. And when you're not doing that, you're in the water or on the water, swimming, kayaking, stand-up paddleboarding. I love that so much. Traveling, cooking, while listening to music, drinking wine, and living life to its fullest with the children, husband, and friends. Did I get that all right?
Got it.
Awesome. Well, thank you both. I know, Brad, you lead a team too at Galileo because sometimes I'm causing trouble on those teams. So here we are. We're here really to talk about telehealth, which you guys have done for a while. So I'm going to start in with my first question. And Bernadette, I'll start with you, and then Brad, you can answer. So how did you get into telehealth?
It happened kind of by accident for me. I didn't come out of my nursing program thinking I wanted to do telehealth or virtual medicine. I was hired by a little old tiny startup called One Medical. And I was asked to do an experimental role, which was called a hybrid role. And I was the very first person to be hired into this, where I did virtual care part of the time. So 2 days a week. And then I did in-person care 2 days a week. And the experiment was successful, and it grew into a standard role at One Medical, and very much is a part of their existing hiring practices with providers. So through my role in virtual medicine at One Medical, I was prepared during COVID when I was the prenatal team lead at One Medical. And we had to figure out how to take a very traditional prenatal structure where patients came in all the time for their appointments and suddenly turn it into something virtual. And it was, again, really successful. And it has shown me over and over again, my 15-year career, the power of virtual medicine to reach out to people and to create greater access to care. And it continually blows me away what we can do.
I have about 70 more questions since that, but I'm going to go to Brad, and then we'll circle back to some of those questions. Brad, how did you end up in telehealth?
Yeah, mine's not dissimilar, but a little bit different in the sense that I had a practice, full family medicine, full sports medicine practice, working 60 to 70 hours a week. My family's important to me. And so, as you mentioned before, and I was just kind of thinking, what else is out there? It was in the height of the pandemic. And really, I was one night, another company was advertised on TV. And I was like, I've never thought about telehealth. I wonder. And so I literally Googled it, and Galileo popped up saying, hey, we're hiring clinicians. And so kind of like, well, I'll just start kind of knocking on doors, explore the option, and really love the idea of exactly what you've said about access and being part of something, kind of helping to form and build and use a totally different part of my brain that I've ever used, and kind of start thinking about, well, how would you do sports medicine on telehealth? And so that kind of just got us excited, and we thought we'd give it a try. Honestly, when I started, I thought I think the COVID really taught us that telehealth was going to be here to stay. And so I kind of wanted to get some experience and be an early adopter. And I kind of thought it'd be a 6-month to 12-month ordeal. And here we are, 3 years, and I can't see ever doing anything else. So I'm excited.
Very nice. Yeah, no, I agree on that. Amy Bruno actually called me up while I was driving somewhere else, and she said, hey, we'd met on social media through Twitter years ago. And she's like, we're looking for people, and you do family practice, and you know diabetes. Why don't you join us? Like, I'm like, all right. But same, I thought, we'll do it for a little while. We'll see. And here we are. Yeah, definitely. Bernadette, did you find that patients were resistant at first to that method of access, or did they buy in really quickly to telehealth?
Because I think it was so built into One Medical's model, and patients were really kind of attracted to this idea that they could get virtual medicine as an adjunct to their care. I think it attracted people who were already open-minded to that. So I have never really experienced any kind of resistance to that. And sometimes I hear people kind of say like, oh, well, I'm going to go see my real PCP. And that always makes me laugh because, we have this idea that the brick and mortar in-person PCP is, somehow more real than what we are doing, but we are actually talking with the patients far more often than those providers get an opportunity to do. Like, we are literally in their homes with them when, like, we can see like what's happening, what their life is like. Like, we get to meet, their children who will pass through the camera, their pets that come across the screen. Like, we are in their lives far more than an in-person PCP gets the opportunity to do. So I feel like I've not really experienced that kind of resistance or bias, luckily.
Yeah. I feel like maybe the resistance is sometimes more among our peers who practice only in person, but maybe that's not as much
It's
as
just
it
because they're
used to
jealous.
be. Possibly.
No, I think it's also one, I think technology can sometimes be a barrier for different people. So that's going to be there. And as technology has become more incorporated in our lives, younger generations who've grown up with more technology than the three of us sitting in this room, they're going to be much more comfortable than our generation, who's more comfortable than the generation ahead. Not to say there's not an 80-year-old that's not comfortable, but it's definitely easier to adopt. But I think that's true. I think all of us were taught, right? Like this idea that, when you come for a physical, I have to listen to your heart, and it's going to change the way I care for medicine. And then I kind of stop and think about the thousands of physicals I've done and think, how many times has it really changed? It has, there's definitely times, but it's much smaller than I think the tradition that we've been taught. And so how much is tradition? Just asking that question of, do we really? And sometimes the answer is yes. Yeah, we really do. But sometimes it's like, oh no, this is just kind of what we've been taught. And so just asking the question, but do we? So I think I agree. The peers, it's a lot of times harder. They think you're less of a clinician if you say, oh, I do telehealth. They're like, oh, why? So
Yeah, tradition. I could hear the Fiddler on the Roof in my head. Nursing holds on to tradition. Like, oh, like I'll still have some people say to me, gosh, I really still wish we had white hat ceremonies. But no, we don't wish we had those. I think that's a good point. Do you two find that doing telehealth has taxed your brain as a clinician in new ways you never thought you'd use? Like I find myself going, oh, wow, my brain kind of hurts today after, not like when I was in the office.
Yeah, 100%. I think, you know, when a patient comes to you with shortness of breath, for instance, finding ways to really help understand what they mean by shortness of breath, since we can't necessarily put our stethoscope up against their chest and hear if there is wheezing, you know, hear if there's a lack of breath sounds in an area. So really helping the patient understand why we're asking the question, I think really helps that process. I think also really getting at, like, sorry, I forgot my train of thought there. Hopefully we edit
That's
that
okay.
out.
No, we derail all the time. No,
Brad,
we're leaving
we're
leaving that in. Don't edit that out. That was great.
Yeah, I think that's true. It's, again, kind of going back to that. Okay, this is how I was taught to do something. Is that the only way to do it? Is there another way? And so, you know, musculoskeletal medicine, sports medicine, that's really hands-on, very much so. And so, okay, there's going to be limitations. There's going to be things I really need to push and pull and do a Lockman test and things of that nature. But there's also some things that I can instruct the patient to do through. And so, and I think we're just scratching at the surface of those things. And you talked about shortness of breath, and you can say, hey, why don't you go walk in the other room and come on back, and then see how, you know, okay, are they still able to speak in full sentences? Am I worried about that? So I think that's true, and you know, stretching us. And again, I always tell people, you know, I was working 60 to 70 hours a week, and when I first signed up, I was like, hey, I could work 40 hours pretty easily. And they're like, we're going to start you at 20, 22, and we're going to see how you do. And I was like, oh, this will be a piece of cake. I'll have all this extra time. And if you hit it and you hit it hard in 22 hours, you're mentally exhausted, because it's kind of like the ER. You're just constantly in and out of patients. And so that was a surprise to me of how much mentally taxing it was compared to in the office.
And I remember my example I was going to bring up.
Okay, let's hear it.
Hydration. So for instance, you know, we can't necessarily like see if there's like tenting. We can have a patient try that, but then just really getting very detailed with your questions. For instance, you know, how do you know how to measure your heart rate? Can you tell me how fast your heart rate is? Like sitting with the patient and actually timing them, you know, while they are measuring their pulse, like asking about how long has it been since you've urinated, and having them really think about that, and just really getting very detailed with your questions, as opposed to just relying on that in-person presence where we could lay eyes on them.
Yeah.
I think it's so much more important.
I think both of those, you guys both make excellent points. One thing, and I taught advanced health assessment at the graduate level for years. We teach that hands-on exam like nobody's business, but the first week we do health history and then we're done. We do not teach people, clinicians, how to get at what's going on. And it's very Sherlock Holmes-like, right? Asking the right questions and putting that together. And this job has forced me to do that, to use a health history as the tool to get to a differential list that doesn't take too much. And then if it's beyond my scope, it's beyond my scope, or I think somebody needs to lay eyeballs on them. And so there's all kinds of advantages to that. I also think it's increased the patient's health literacy that I deal with. They come to us at first and we have to explain so much to them. Why do you get a PQH9 every single time we see you? Well, this is almost like a pain scale, right? From 0 to 10. We're measuring how much depression symptoms you have, and that tells us whether you're better, whether the medications work. And so then they come to expect it, so that they can go on then, if they're seen in person, and have better conversations with other clinicians. And I'm shocked sometimes by what patients can tell us and how much they buy into that.
I think you're right.
liken it to, oh, go ahead, Brad.
I was just going to say, like, health literacy today is so much more in depth than it was 20 years ago, because the access to information is just so easily, it's so tangible. And so a mentor of mine once said that, a patient will tell you the correct diagnosis about 90% of the time, and then testing, exam, imaging, that's just to confirm that 10%. So, and honestly, when telehealth, that's kind of what it tracks out. I feel like I can do about 90% of what I could do in office pretty well. And then there's that 10% of the time, I just need that little extra bit of information that I may not have access to. And so, yeah, I think it's part of that is because patients are just have such a higher health literacy across the board. I mean, obviously there's differences between individuals, but across the board, it's just so much higher.
So, like, we're all here and we're practicing in it, so we're biased. But from what you know now, would you say this is a legitimate way to access care, even to source as a primary care source for patients? And how do we get that across, like, to the rest of the healthcare system? Either one of you, Brad, go ahead. Tell me.
All right.
What you think
Yeah, absolutely. Like you said, I know I'm biased, but I think there's a shortage of clinicians nationwide, especially for our rural communities. I'm from a rural community. I've practiced in rural communities. And so it's really hard for people to get good care. Like today, I don't know, and I live in a town right now of 80, 90,000, and I don't know of a primary care provider in the greater area that has availability. And so it kind of is just a microcosm of what's going on. So truly, what I foresee in the future is let the routine follow-ups occur in telehealth, but let people have an established brick and mortar place where when that 10 to 20% comes up where they need that in-person exam, great. And that now allows that provider to see 3-4 times the number of patients in their panel, and we can kind of share the load collectively and decrease the overall cost of the medical system. We can't do it all through telehealth, but obviously the system can't handle it at all without it either. So I think it's a viable option and can be really helpful to help bridge that gap that we are currently facing.
Yeah.
Very well said.
Bernadette, you worked somewhere that was already a buy-in from a women's health and a prenatal standpoint. Like, what would you tell the rest of the colleagues who are only seeing patients in person about telehealth as access to care?
Well, we really have to start thinking this way because of these maternity care deserts. Patients are showing up in emergency rooms across the country and delivering babies because they've not had any prenatal care in their pregnancies. So we have to start thinking about ways that our current prenatal structure is not working for them. And how can we expand prenatal care to encompass patients who have limited access to transportation, who have, childcare issues that constrain them? Like, it's no longer possible or really workable to have to take time off of work in the middle of your day for a prenatal appointment. And that provider could be running behind because they have such a huge patient panel. And suddenly they're out of work for 3 hours for a 15-minute prenatal appointment. That is not working. So I think that everyone, even if they think, wonder how we can do safe prenatal care virtually, is thinking about how our current system is failing so many people and is not working for so many people. And we have to be thinking more open-minded about solutions for this problem.
I agree. 2 points personally. I have a sister who's now a travel nurse in labor and delivery, and she's at a critical access hospital 3 hours outside of Phoenix. And the majority of the patients who walk through her door have had no prenatal care because there's no access. There's one OBGYN there at the hospital for like a 3-hour area. And it's a problem, right?
Right.
We're never going to tackle maternal fatality rates or fetal maternal mortality rates without that. But on a personal note, I'm one of those people that buys my own health insurance, and I have not fun insurance and hadn't been for a physical in a couple of years. So I went to see my NP recently, who, by the way, retired. So I got a new NP, and her collaborative practice physician retired, and I'm very sad, but it's a post-COVID effect. So I went into the office. I was seen. They were running behind. She didn't know me. She asked 2 questions. She did listen to my heart, Brad. And then she told me how exhausted she was, and she left. And I thought, oh, I had a million questions. I'm like, I'm going to go to my Galileo app because I know we get way better care there. I just know that I'll be heard, that there'll be good questions, that I can ask my questions. If it's nothing, I'll go. So I went back to the app. I'm like, and personally, I'll probably use Galileo instead of being seen in the office.
Mm-hmm.
No, I think like, one of the areas that I've really seen what I can do better now than I could in the office is like depression, anxiety is a really good example. To Bernadette's point, like I can spend all day talking to this person. It can wait till before work, after work, whenever it's convenient for them. So that's one less stress that they have to kind of deal with. And then on the flip side, I don't have to fear the waiting room that's just continually building up and feeling that pressure of, oh, I need to spend another 10 minutes with this person, but that's going to put me behind for the next person. And that guy, he's going to let me know that I made him late. Now he's missing his work or lunch or whatever it is. And so you're not playing that game of like checkers in your brain all the time. And I can just take care of the person as they need the care. And so that's been really refreshing that I know, hey, if we need to talk in 2 days, we'll be here. If we need to talk a week from now, we'll be here. And hey, 2:00 in the morning, guess what? We'll be here. And so that's been really rewarding to know that, okay, this is better than I was doing just on my own before.
Yeah, I agree. The 24/7, I don't know if all telehealth works that way. And the camaraderie we have with this group of people, and we have all these people with these beautiful expertise. I feel so safe walking away from a patient or someone picking up the chart behind me or like rereading something or reaching out and going, hey,
Right.
remember this patient? I'm like, oh, yes, thank you for catching that.
I was talking to a colleague the other day who said that she had such a busy week and she had to spend her entire Friday, her day off, charting from all of the patients that she saw that week. And I was like, oh yeah, charting.
I remember that.
I kind of forgot about that because, we have engineered such a unique way of documenting our video visits and our messaging with patients that there's never a time where I have to recall anything and go back and chart on that. I mean, think about just even the lack of, memory recall or reliable information that you are documenting, from these patients. If you saw them on Monday and you're finishing their charting on Friday, like to be able to chart in real time about what is going on with your patient is it's just better for everyone. It's better for the provider and it's better for the patient. And it's just so much more efficient.
Yeah, I completely agree. And even though I know that some things take more time, like we may be talking 2 or 3 days with a person to finally get where we need to get, I don't feel the pressure to wrap something up, write a script, and send them on their way without true resolution or full understanding of what's going on. That used to scare me to death.
Right.
And then you don't see them for 3 to 6 months. good luck on this drug that might kill you. But won't check back in. Okay, so it's an advantage. It's 24/7. We are not spending our days. I feel like it's transformed it's given me hope in a healthcare system that I thought this is all going to need to be burned to the ground and started over. And telehealth is not that way. It's like this new, and the number of rural patients, uninsured patients, adult Medicaid patients, like we are a viable option. And Brad, you said there's no access in your area to new the main office for NPACE is outside of Boston, and one of those hospitals said they can't take any brand new patients into family practice for a while, a huge Boston health system. So it's not just rural. There's not enough clinicians.
And I think one thing we haven't touched on yet is that many providers are burned out. And this is why we have these healthcare provider shortages. And this is why it feeds into maternity care deserts. Like in-person providers are overworked. They have too many patients. There is, like you can have a full panel day, which is 50 patients, and then you're getting fit in, for other patients who really need to see you. And then on top of that, you're having to refill medications and review labs and look at x-rays and orders. And it's too much for one person to handle. And that burnout is real. And I really find that doing virtual medicine is such a great option for provider burnout. Being able to, work from home and in the comfort of your home. Maybe you're physically home when your children get home from school. You're not scrambling, to pick them up from after hours, by the last minute like I used to. And I think that, being able to have a load of laundry that's running, before your shift started, like those are huge little things. Like, oops, I forgot to take out the chicken and defrost it. Like, oh, here, let me hop up and take the chicken out. Like, it allows you to kind of be in your life, but yet still do your job. And I really think it's a viable option for providers who are suffering from burnout. Like we were saying before, it's not easier than in-person care. It's different, but it does allow you some time to do some self-care and still care for your family. Like many of us are, we're working parents in addition to doing our jobs and caring for people.
Mm-hmm. Brad, you have a teenager. What do you think about what Bernadette just said?
No, for sure. When I was on the sideline for sporting events, one of the things that was kind of glaring me in my face is I have at that time, 10-year-old, 11-year-old, and I knew the time was coming where I'd have to make a choice. Am I going to spend time on the sideline watching other people's kids play sports, or am I going to be on the sideline watching my kid play sports? And it was a hard thing to wrestle with, because I love sports medicine. Like I love being there and rooting on the patients, and they know you're vested because they see you at 9:00 at night and 7:00 in the morning. Like so this relationship you develop is very unique. But on the flip side, I don't like it as much as I like my family. And so, last night I got to just at 3:00, my daughter's game was an hour and a half away. And so I could just go. And if I was in a normal office, to leave at 3:00 in the afternoon, it's not feasible. And, I was sitting next to a mom of one of the players, and the dad is a physician, and he wasn't there because he's, working. And so, I respect that, but it was just something, and we don't all have this luxury, if you will. But I was grateful for the opportunity that I could. And so, I think that's a really hard thing. And you kind of, Terri, you actually mentioned something that if I can, I'd like to circle back to. One of the ways I see myself as a better clinician now than I was in person is because of that collective wisdom. We have providers who have trained all over the country, and I never realized it until now, but the training one person gets in a rural area compared to Boston, to compare it to California, is really different. And not to say one's right or wrong, but we all know there's an art of medicine. And so I get to see that different art. And there's certain things where I've now kind of had this realization, like, man, I was missing that for years. I just wasn't taking as good of care. I've been able to glean from people like Bernadette, who's, from their prenatal care. And I'm like, gosh, I've missed that for years, that this is the higher level of care that I wasn't providing. And so having that collective wisdom that medicine is so broad now, there's so much information that not any one person can be great at all of it. And that's kind of what we expect of our primary care. And so that's one thing that another strength that I've seen, that it would never happen in the general practice under the current model. Because I'd go into a room, I'd close the door, I'd type my note, I'd make my decision, and I'd walk out, and very few people were ever looking at what I was doing. So.
Yeah, I agree with that. Yeah, go ahead, Bernadette.
And it's another reason for provider burnout. That demand to be the omnipotent, doctor or provider is a lot of pressure when you don't know something and you don't have time in your schedule to reach out and consult or ask about. I mean, that is built into our structure with our team approach with our patients, is that at any time we can reach out to each other and say, hey, I'm not quite sure about prescribing this GLP-1 as a monotherapy, for this diabetic patient. Like, are we moving in this direction? Like, should I start them on metformin first? And like right away, I have 3 providers who are like, hey, let's talk about this, and taking a look at the patient's chart along with me. And it's a true collaborative team approach.
Yeah. There's not one shift that I don't work, that I don't walk away where I have learned something from someone else. And it's phenomenal. And it feeds that enjoyment of going to work. And it makes me a better clinician. You're right. I get the privilege in this job of talking to clinicians and experts everywhere. So we did a podcast with Jessica Peck. Jessica Peck is the past president of an organization called NAPNAP, the National Association of Pediatric Nurse Practitioners. NAPNAP surveyed pediatric nurse practitioners about a year after COVID, 2021, and then they did it again in 2022. That's what I was looking for over here. I was looking for when we talked to her, and I wrote this down. So they surveyed their entire population, and they're rainbows and unicorns and sparkles and stickers, and I worked in PACE for years. It's supposed to be the happy place. 80% of those NPs felt burnout, thought they were depressed, and had mental health issues. And the majority of that 80% were thinking of completely exiting the profession. And this was pediatric NPs in an office being supported. I'm like, wow, what's that mental health? What's that look like for providers as a whole? Maybe we should do that research. Telehealth versus in office. What's their quality of life and mental health scores?
It's one of the things I noticed when I have to go into an office myself. Like, it is very palpable to me how happy or content the staff appear, from the front desk interaction, to working with the MA and chatting with them, to the provider that comes in. I mean, you can tell immediately how present they are with you, because of how happy or content they are in their work and in their job.
Some of that might be patients, though, and what patients, because I can sense when they come to us telehealth and they've already been burned by the system somewhere, and they're so frustrated, and there's so many hoops to jump through, and they waited 2 hours in the office and they never got to a specialist, that they're already defensive, right? When we start talking to them, how do we overcome that? I've gone way off script here, people who are listening, just so you know. But I think patients are frustrated. So either one of you, Bernadette, we'll start with you. How do we overcome patients who are really frustrated with the system already when they come into telehealth?
I think starting with empathy and realizing exactly what you said. Why are they frustrated? Why are they feeling defensive? Why are they feeling guarded? What has their experience been? Because, we all are humans. Like, we all are part of this healthcare system here in the United States, whether we are providers or patients, because providers are patients too, and we all have experienced these frustrations. So I think we can really understand where a patient is coming from and realizing, you've just met this patient. It's really not about you. It's about them probably being told that there's nothing we can do for you. And yet they still have this pain. And so starting with the patient, really understanding where they're coming from. And then I think really letting them know that we're listening and that we really want to understand what's going on. And I really find the way that I interact with patients, if I explain why I am asking what I am asking or what I need to know, I really find that patients really appreciate that, because otherwise it just feels somewhat pedantic, that I want to order these tests. Well, why do you want to order these tests? Are you just doing them because you think that you should, especially for patients who are on a limited budget or have a high deductible plan? Like, I think it's really important to say why we are ordering a CMP. We want to see your electrolytes. You've been on this medication for a while. When you've been on a medication for this long, we need to see how your kidneys and your liver are functioning. Like, I think that's when they're like, oh, okay, that makes sense. I'm willing to spend money on that. And I think as providers, we really need to stop and think about the tests that we do order. Like, do you have to have a pregnancy test every time you go into a women's health office? Maybe, depending on what's going on. But that's an extra expense for the patient. Like, do we have to do that? Let's give them a chance to really say what they want to spend their money on by explaining it to them. So I think involving them in the decisions by sharing with them the reason that we want to know what we want to know is really helpful, and it really engages them in the process. And then in doing so, it makes them know that we are a team in this. It's not just us telling them what they should do.
Yeah, I think that's a good point. Brad, I've seen your interactions with patients. They're great. And often you can motivate someone to get them where you need to get them. What do you do with those patients who are super resistant or come in with their gloves up?
Yeah. And, I actually, I don't know if you two know this about me, but for the last 2 to 3 years, I've actually had a private practice as well, still maintaining in-person sports medicine, up until just about a month ago. But even there, so this is true of all medicine, telehealth, in person. I had a mentor who's like, give the patient 4 minutes to tell you whatever they want to tell you. Don't interrupt them. Don't ask questions. Just let them talk. And so I try to follow that. I try to let people, hey, you're here for a reason. You probably have Googled that you are dying. You have these things that you're coming in with information, and you're taking your time and your money to get my opinion. And so let me hear. And there was basically my practice, and there was another practice in town, and the other practice, they were really good at churning out numbers. Like you said, 50, 60 people a day. And let's be honest, that they are rewarded financially because of that, right? Like it's how you make good money in the modern model. But patients would always walk away and they're like, he was looking at the computer the whole time. He maybe listened to my heart, to Terry, what you said. And then afterwards, 5 minutes later, he said, go off and do this thing. Now, about 75% of the time, I would exactly agree with that provider's care plan. But the patient felt listened to. I explained it to them why we were doing it, exactly what Bernadette said. And the person was like, okay, I can get behind this. I can agree. I feel like I've been heard. I feel like all the details have been addressed. And so now I have comfort with the treatment that's being recommended, even if it was the exact same treatment. Like, you have a cheeseburger on the left, you have a cheeseburger on the right. The one costs $2, the other costs $50. You're going to think the $50 one tastes a whole lot better because you have this perceived benefit. And so just the fact that you stopped and you listened and you let them speak and you talk to them, they have this benefit that, okay, everything was listened to. I can get behind this plan. So you're not going to make everybody happy. It's expensive. They're scared. People are going to be on guard all the time.
Yeah.
But I think that's about as close as you can get. Just remembering they're a human, and okay, if it was my loved one, how would I want them listened to? How would I want them treated? And it's easy to get into it's our job. So every day we're just chugging through, and it's easy to forget that on the other side, that somebody's mom, dad, brother, sister, kid on the other side. So just remembering that.
Yeah. I do think telehealth is a viable option for getting that, because people can text in. They're so used to just texting their thoughts. Oh, by the way, this happened today. Oh, what about this? And it is so much more access to hear those things, Brad. I think that's such a great point. Okay, let's see. We could talk about this forever. First I want to ask things that are super complicated that don't bode well in telehealth, but now I think about it, they might be difficult everywhere. So what's really difficult to parse out in a telehealth setting? And there may be nothing. That list might be small. What do you think? Bernadette, you go first.
I feel like neurological issues are really hard to parse out virtually. That's where I really want to be able to kind of be in the presence of someone, because, as you both can attest to, when you've been doing what we do for as long as we have, there is a gestalt that exists. And, perhaps that's what is a foundation of what called us to do this work. But there is a sense of something not being quite right. And we can certainly get that from virtual interactions and doing video visits. But I haven't been able to test that as much, like Brad's cheeseburger. I can't. It would be interesting to do a study on that, like how much your gestalt comes through, virtual medicine. But when somebody has so many complex issues that especially neurological, that cross over so many different body systems, that's where I really feel like being in the presence of a person is really powerful.
Yeah, I agree with that. Pain often masks things. So anytime there's pain involved, I think we all as clinicians tend to fall onto the exam to some extent. Like, oh, my whole stomach hurts. Oh, does it? I'm going to press. Oh, no, it's really just your left lower quadrant. Okay, now my brain, my list of differential, 75% just went out the window, and now I just have to focus on these. So I think pain, and so a lot of times the neurologic conditions. That being said, not to argue with you, Bernadette, but 2 weeks ago I had a Guillain-Barré case that was positive. And honestly, for those listening, we have these forms that people fill out, not much different than the questions that the nurse asks when you walk in the room. But then the patient's like, hey, I'm really having a hard time walking my kids to the bus stop. That's what they said. And so at first it felt like it was just pain, but something about the way it was phrased made me go, oh, that's a little bit different. It's just a little bit. And obviously through sports medicine, musculoskeletal, we have a kind of that next level of training. But so I got her on video, and the lady's like, yeah, I can't get off the couch. She's like, my legs are just too weak. And I'm like, So now, granted, I'm like, I think you have Guillain-Barré, but I need you to go someplace to get diagnosed with that. I can't diagnose you from telehealth. And sure enough, it came back positive. And so I think it's because we let her talk and tell her story of what this was really bothering her, what part of her life this was affecting most. It was like that light bulb moment where it was like, whoa, this is probably something that, if I saw in the office and I had and I wasn't spending the time, I was just chugging through, you could see how somebody would say, well, let's just give you some anti-inflammatories and send you on your way. And so you can see how that type of thing would happen pretty easily.
Sure.
And
because she wouldn't even have been able to make it into the office because she couldn't get off the couch. So
and she was actually seen in an urgent care. Yeah, she was seen in an urgent care, and then she just wasn't getting better, right?
Right.
So yeah,
it speaks to that beautiful integration between virtual care leading to, really sussing out who needs to be seen in person and who needs specialty care.
Yeah, I definitely think sometimes all we can hope for is to be a good triage, right?
Mhm.
Like abdominal pain and pelvic pain is really tough because it typically involves I need testing pretty quick. I need, that UA becomes really helpful. And so in the office, I'd have that in 5 minutes. Here I have to send somebody and it might be 24, 72 hours before I
Yeah.
get the results. And so, sometimes I think we're really stuck as um, a good triage to just tell the person, oh, I think it's okay to wait. I think you need to go to a family practice office and be seen in the next day or two, or no, you need to be seen today. And but that has value too. It's not that I don't get to, put on my badge, aha, I diagnosed this today type thing.
Yeah. No, I think beyond that, chronic pain patients, but I wonder if they're difficult everywhere. There's just so much more complexity and usually multiple issues. And I just, it's locking them into everything they need and still not feeling like you're getting ahead. Sometimes mental health is the same way that patients just aren't feeling better and aren't feeling better. And that's, of course, plays right into specialty care. I'll be honest, sometimes the acute infectious disease on a platform like this, and like, oh, this is the time I wish I had a stethoscope and a rapid strep test and a flu test and a urine and I could feel your abdomen. Like, and those people just want a Z-Pack and to go away. And sometimes I'm afraid if we send them to urgent care, that's exactly what will happen and reinforce that. No, no. So those are the things that keep me up at night.
Yeah, no, I think that's true. Um, I had a thought that you kind of brought up.
Because
And
you're
then
trained to do.
contraceptive medicine, like we can do so much with contraception. We talking about access to care, like a patient doesn't have to take time off of work to go pick, to be prescribed the pill. Like we need this now more than ever because of, our restrictions here in the United States. And we can definitely do that without seeing the patient in practice. But if they want, an IUD, if they want Nexplanon, obviously we cannot do those procedures. And so again, that seamless connection between helping out these in-person providers by seeing the patients that we can help virtually really just sets them up for a more efficient process with patients who actually just need those particular contraceptive procedures. There's such a win-win in that situation.
And I think the chronic pain is kind of that double-edged sword, Terry, to your point. It's hard. It's going to be hard no matter where you are.
Right.
But in the telehealth world, I'm able to say, hey, you've been through a whole lot and it hasn't worked for you. There's still these 5 things we'll say that we would like to try that you haven't tried yet. But here's the good news. We're going to try it this week and we're going to circle back next week. Versus when I was in primary care, I'd be like, I'm like, in my back of my head, I'm thinking, I'm 3 to 4 weeks out. How am I going to squeeze this person in? And so the patients get disenfranchised because they feel like that's just another doctor and he's going to throw a pill at me and then he's not going to see me for 3 months and then we're just going to repeat this whole thing again. And so I think it helps the patient say, okay, it's a much smaller and we're gonna walk with you through this. And hey, if you have a side effect to this medicine at 2:00 on a Saturday, guess what? We're here. So to kind of circle back to that 24/7 thing that we've already mentioned.
I like that language that we're going to walk through it with them. I think that's powerful language. Bernadette, I'm going to agree from a diabetes standpoint. I have found, much to my surprise, that telehealth is a much better platform for managing diabetes. It just is, because there's so many pieces and moving parts and we can keep that conversation up and I could get blood sugars and it is not an every 3 to 6 month visit. It is a beautiful way to manage type 2 diabetes, which we know is like a third of the patients we see. So, and I think patients are satisfied with that and feeling like we can.
And you can also, like, along those same lines, you can kind of get a sense of where's this person at as far as diet? Where are they at as far as exercise? Are they ready to start exercising? No? Okay. That's, and so you have a little bit more of a sense like, I don't have to get it all in today. I can, hey, I know I'm going to check your sugar in 2 weeks. So I can put off asking you about exercise 2 weeks from now. Like, let's just one step at a
Agreed.
time, not
So
we don't have
true.
to throw everything on and expect it.
And I tell my patients when I do an annual wellness exam, at the end, there are several issues or concerns that you have about your health that came up in the course of our time together. And I'm going to open new cases to discuss these issues, but please don't feel overwhelmed by that. You don't have to do this all. It's not like going into an office visit where you only have 30 minutes with your provider and you have to cover all these topics. Like, we're here. So let's prioritize the top things that you're worried about. Okay, you want to get your blood sugars under control. You want to get your blood pressures under control. Let's prioritize those. Once we have that, in the next couple weeks, then we can talk about your colon cancer screening. Like, you don't have to do everything at once.
Mm-hmm.
And it really gives them ownership over their healthcare.
Which is how it should be, right? Whatever their priorities are. I've even noticed that patients will bounce back to us after we've sent them to the specialist because it takes so long, or they can't get back in for refills or co-management. And, I was raised in a healthcare mindset. Once the specialists got their hands in it, that's who you see for all of those things. But we're going to have to let go of that, because patients will say, you guys respond fast. I can't get the other office to respond to me. It might be a week or 2 or 3, or I have to go back in for a refill. Although there are some things more complex than we should be managing. But yeah, that co-management, Brad, that you talked about in the beginning, I think will be important. Yeah. All right. Last question, because we talked forever and I knew that would happen. What do you wish you had known coming into this, or one tip for clinicians that are thinking about telehealth, or what they should be telling their patients about telehealth?
And I'll apologize up front. I don't know if you can hear my dog in the background. The trash can, the trash truck is here, and he's protecting me from that. So
yay!
Harry,
No,
can you
that's
still
fine.
come back?
Yeah,
Okay.
we like pets and children on the podcast, I'm sure.
I think my biggest recommendation is just to kind of challenge our training and just say, is this a viable option? Is this something that is right for me? Is it right for my patients? Don't just kind of assume it's not, because it's different. Just challenge yourself to think about it. What are the shortcomings? What are the benefits? There's both. But kind of think through that and be willing to just think of it and then go from there.
That's a good point. Bernadette, what do you think?
In preparing for this, I had made some notes for myself, and almost exactly what Brad said. Like, I think I did not know when I stepped into doing virtual medicine or telehealth medicine, I was not prepared for this constant question that I ask myself every day, which is, why do we do it that way? What is the traditional model, and why has it become the traditional model? Where is the evidence on that works? And I'm constantly asking, why do we do it that way? Does it have to be done that way? And you can take that from a macro level, on all of our healthcare systems, or you can bring it down to the patient, well, this is what they've been taught, but this is clearly not working for them. So how can I, as a clinician, help to undo that, and also say, well, if that's not working for you, what can work for you? How can we do this differently for you? Is it more follow-up? Is it keeping a symptom journal? What is it that we can do to try to get at this in a way that hasn't been done before? Because we maybe have more time with the patient, and more, patient has more access to us.
Yeah, I think that's really well said. I come from a faculty perspective. I taught for many years while I held a practice, and I think we're doing it wrong when we teach. We should be teaching from this perspective first, other than all this hands-on and here's the lab results and here's that, from this perspective of investigation, questioning how important that health history is, and this kind of dialogue about what and why, cost, problems, all of those things that we're finding in practice. I just don't think we're teaching from an educational level forward. So I think those are good points. We could do a whole nother thing on the system and state licensing, and shout out to my home state of Missouri that won't allow NPs to do telehealth outside of that. Yes, Missouri, talking to you, change the law. But we'll get there because there's access to healthcare issues. We all know that, and it impedes our patients every day, and they have to have access. We got to have access to care. They can't not. Yeah.
I think we've gotten used to that as patients. Oh, my provider won't have time for that. Or, I can't ask too many questions. I won't be able to get in to see them in a certain period of time. It limits the patient's thinking what they need. And so if we can change that, where patients are saying, no, this is what I need. How am I going to communicate this to my provider? Because they're open to hearing that. That's everything.
And I think we've all, sorry. Yeah, I was just going to say along the same lines, and speaking to the states that access is an issue, which is everywhere, but, or who are putting like barriers there, like, how many times in our practice did we, in our traditional model, is like, oh, I'm going to put you on this blood pressure medicine, and then we're going to see how you're doing on it. And then patient comes back a month later or whatever, and they're like, oh, I took that for 3 days and it just didn't work for me. So then you're like, oh, I just lost a month. Especially when you're talking about like diabetes and things, you're like, oh, I wish I would have known, but if the patient would have called and been like, how am I going to squeeze this person in? So just allowing the patients to have that accessibility to meet them where they are outside of their work schedule allows them that, hey, I'm just going to tell you real time, I'm having this side effect. And then sometimes it's just that normal side effect. Okay, just give it 2 more days, it'll get better. And then sometimes it's, okay, that's the wrong medicine. Let's try something else. And so having that access is just really changes how we practice.
Yeah. And we're certainly, just to clarify, not saying that in-person care isn't needed. It's absolutely needed, but they're overwhelmed. And I think there's a beautiful partnership. And I think there's a place for an organization like Galileo to work. Like if I was every day in an office, I absolutely would be telling my patients, you need a telehealth app and we can work with them. Somebody I work with, and it doesn't even have to be that one medical model, Bernadette, because one clinician can't do it all. And for the $250 I pay for Galileo for my kids who are going to college or whatever, it's invaluable. It's just this amazing co-requisite and just such a beautiful blend of bringing things together and access that people don't run out of meds, or they can say, I'm having some swelling in my legs with this amlodipine, so I just stopped it, or I felt dizzy, or agreed.
Yeah, last January, I had a good friend from residency have a medical issue, and he's in a small town in Idaho. He's the full scope doc where he delivers babies, does ICU, does the EGDs and colonoscopy, and all of a sudden he had to take 2 months off because he was just, and so myself and another friend from residency were like, hey, we can come and help. And it made me realize, man, he loves in-person care and he does things that I couldn't even dream of doing. And he feels really fulfilled by that. And that's awesome, right? Like just that doing everything and being that person. Everybody in town loves him and knows him. And but on the flip side, I see how tired he got and how he was he was at his kid's game, and somebody, 3 people were coming up and asking medical questions. And so I was like, man, this is a beautiful symbiotic relationship. He doesn't want to do telehealth, and that's great. He loves what he's doing, but I could come alongside him and just say, hey, you see, and I'll take care of the diabetes in 3 and 6 months, and then they'll come back and see you, and it'll just be this nice kind of fluid. Exactly. And I think that's the future model.
100%.
I hope so too. Brad and Bernadette, thank you for coming and talking about this. I'm so excited that we are, because nobody really is talking about the true benefit. True. Of telehealth. Okay, well, maybe we'll talk about this again in the future. That would be great.
Thanks for having us, Sam.
So honored to be here.
Oh, I really appreciate your time. I know that's the most precious commodity. We can't make more of that. So truly, NPACE is honored. For all of those listening, you can certainly check out all the other podcasts. You can go to npace.org for all things NPACE. The podcast is on Spotify and it's on Apple and it's on YouTube where I like to listen. We are an ANCC accredited provider, so there's plenty of CE out there for you. But thank you so much for tuning in. And this concludes our Friends of NPACE podcast with Brad and Bernadette, and we've been talking about telehealth. Thanks, everybody.
Woohoo!
Thanks. Oh man, this is so great. We need to talk about this more.
We do.